Saleh, Professor of Internal Medicine and Endocrinology. I started an obesity clinic, and so I am presenting this lecture for you. Actually, I have presented this lecture yesterday, but actually my way of teaching is different. It's not just one way like this. I would like to be interactive. So, Wallahi, they told you that a lot of information. No, there is not a lot of information. Some information in it just for you to know something. It's not meant to be to study. For example, fat diets, a complementary medicine. This is not for you to study. Just something. It's not all the lecture you have to study hard and for the exam. Not every lecture like this. First of all, my first question. What is the definition of obesity? What's meant by obesity? This is, he said, BMI, body mass index. What do you think? What is the definition of obesity? What's obesity? What does obesity mean? Yes, excess fat. Yes. Literally, obesity means fat. Adipose tissue or obesity means excess body fat. Okay? This is literally. So my lecture actually, it seems to be a lot of information. No, you find just a slide just with one question and the answer. This is the question. What's meant by obesity? The answer is literally it means excess body fat. Actually, for 1 pound of fat represents 1 pound of storage in our body. Fat, gain or loss, coincide with 3,500 calories. Okay? This is important, remember, because we need it later on. Okay? Next question. Should any gain of weight be considered obesity? No. Why? Yes, he said could be ascites, could be fluid retention. Okay? What else?
Could be gas distension.
Actually, usually by gain of weight we mean obesity, but it may be all edematous states like heart failure, liver cirrhosis, any renal edema, any edema lead to increase of weight. Heart failure patients should be followed by weighing, giving them diuretics, and we weigh them every day. Okay? Increased muscularity could lead to excess fat. Some go to the gym, okay, in order to lose weight, but they start eating. Okay, so he's building muscles, he's gaining weight. Okay, so any gain of weight not necessarily mean obesity. Next question. What are the causes of obesity? Yes, he said maybe sedentary life and the lack of exercise. Yes, of course. Because what? Because of what? Because it's a balance between energy in and the energy out. Okay? So if he eats a lot and he doesn't move or doesn't exercise, so he has to gain weight. But there is something. Why everybody, not everyone, is so obese? Some people tend to be lean and some because there is something, genes, there is genetic background. Yes. But if the genetics is the only cause, so we don't need an obesity clinic. We don't need to treat because it's only genetics. Of course not. Because environmental factors are important. So, genetic background predisposing to our obesogenic environment or endocrinological environmental factors. So genetics, it's usually polygenetics, not one gene defect. There is energy imbalance between diet and decreased physical activity, and then there are some secondary cause diseases like hypothyroidism, Cushing syndrome, pancreatic insulinoma, growth hormone deficiency, hypothalamic insufficiency, all are psychological factors. These are the secondary causes of obesity. Some drugs can lead to obesity, like tricyclic antidepressant drugs, antipsychotics, also insulin and corticosteroids. If anyone receives the corticosteroid for large doses for a long time, could gain some weight. Okay, this is what we meant by not. What is this? What I'm going to do with this? Yeah, just like that. Okay. So we are starting to talk about simple obesity. This is the simple obesity. This is the most common cause. People come to the clinic saying, I might have something wrong with my endocrine. This is maybe endocrinal cause. No. No. Actually, the endocrinal causes of obesity are not so common. Hypothyroidism, Cushing syndrome are not so common. The most common cause is the simple obesity, which is the imbalance between energy in and the energy out. Energy in, foods and beverages, depending on how much, the quantity, how dense food, the energy density, and how frequent we eat. And the energy out depends on three things. One we cannot change, which is the BMR, basal metabolic rate. Why you are sitting down, lying down, we are dissipating energy. There is some energy without doing anything. It's called, basal metabolic rate, okay, BMR. But there are other two types of thermogenesis, which one is diet-induced thermogenesis. When we eat and digest food, absorb food, there is an energy out. It's called diet-induced thermogenesis. The third thing is exercise-induced, which could be just our activity. While I'm talking, while I'm working, while I'm doing dishes, while I'm doing something, while I'm doing anything. This is working life or daily life activity. Besides the exercise, which we can modulate. This is the portion of the thermogenesis which we can increase because we can do more exercise. Okay? Actually, they are showing how much calories can add so quickly, so easily. Yeah, one hamburger like this, 250 calories, and this potato chips, how much? 250 calories.
هو كيسي كيلو كالوري ولا كالوري؟
كيلو calorie. Yeah. It's called the kilocalories. Is just we say it in not in a literal way. We mean by calorie is a kilocalorie. Yeah, actually. This is a list of the secondary causes of obesity. Dr. Kushner was the Obesity Society was doing it. Hypothyroidism, Cushing, hypothalamic, hypocystic ovarian disease, genetic syndromes, growth hormone deficiency, contraceptive pills, medication, smoking cessation, and eating disorders. Smoking cessation sometimes at first associated with increased some appetite, so you gain some weight. Okay, but what is important is what I'm going to summarize later on. This is to loosen up. What is this? This is a rat. He is obese. Okay, and this one, a dog. He is obese also. What is peculiar about his obesity? What is peculiar about his obesity? Okay, you think the trunk is obese and the legs are thin. So he has. Yes. What what diagnosis is? Cushing. Yes, he has Cushing syndrome. Okay. And this patient is having Cushing syndrome.
One face.
And this is Stria Cushing syndrome. This one, polydactyly. There is a syndrome with polydactyly and obesity and mental retardation called anyone remember? Lawrence Mombedel, yeah. Lawrence Mombedel or Bardet-Biedl syndrome. This one is a syndrome of obesity also. It's called Prader-Willi syndrome, characterized by hypotonia. She's the fetus, she's a baby, he's the hypotonic. Huh? Okay. Okay, next question, why should we treat obesity? We can rephrase it like what risks associated with obesity, what are the hazards of obesity? This is why we should treat obesity. But we are going later on to ask the same question and they expect another answer. Okay? So why should we treat obesity? Because they are associated with hazards or risk or associated with risks. If you start all the systems, you like this way, systems, okay? The cardiovascular system, hypertension, maybe later on congestive heart failure, varicosities, respiratory. The patient with the obese person is almost dyspneic. He has also obstructive sleep apnea, like what? Awaken at night with snoring, and during the day he's sleeping. So there is what is called the hypoventilation syndrome and Pickwickian syndrome. Anyone know what's Pickwickian syndrome?
Pickwickian syndrome في COPD 2 جبيز.
Yes. Pickwickian syndrome is a cause. Obesity causes restrictive ventilatory defect and central hypoventilation, causing the patient to have some sort of respiratory failure. The patient characteristically is stocky, obese, and sleepy during the day, and during the night he wakes because of the obstructive sleep apnea. Every time he becomes apneic, so he is awakened and so on. So during the day he is sleepy like this. It came from Mr. Pickwick, a character from Charles Dickens novels. Okay, this Mr. Pickwick, short, stocky, and always sleepy during the day. Pickwickian syndrome. Also asthma. Endocrinal is, of course, obesity can lead to type 2 diabetes, metabolic syndrome, dyslipidemia. Type 2 metabolic syndrome, actually, Dr. Muhammad Abdelhamid is going to give you a lecture about it, inshallah. Polycystic ovary syndrome, menstrual disturbance. Some people come to us at the clinic after losing weight, they got pregnant. Yeah, they have infertility. After losing weight, they got pregnant, so they will be happy. So thinking that the acupuncture is the one causing this. Actually, just treating obesity can lead to regain of fertility. Neurologic causes also psychological. There is depression, disturbed body image, low self-esteem, and impaired quality of life. Some patient told me that when she went to a meeting and she finds a chair with 2 sides, becomes very embarrassed because she had to sit down and she cannot, the chair is too tight for her. This is something diminishing, affect her quality of life and her self-esteem. Okay, musculoskeletal, it's very common. Degenerative joint disease, osteoarthritis, back pain. Actually, hyperuricemia and the gout. Immobility, carpal tunnel syndrome. Also GIT causes. One of the common causes or the important cause of gastroesophageal reflux disease is obesity. Okay? And also non-alcoholic fatty liver disease, very common nowadays and very famous, steatohepatitis or steatosis. Okay, cholelithiasis, gallbladder. Gallbladder stones present in obese and even with rapid loss of weight associated with stone formation also because of increased turnover of the cholesterol. Genitourinary, yeah, sometimes incontinence, breast and uterine cancer, because there is something important which is association of cancer and obesity. Yes, there is definite association between cancer and obesity, but doesn't mean causation. This doesn't mean that obesity causes cancer, but there is an association. This is different than if you have a sore throat, this is caused by streptococcal infection. This is direct cause. But there is association between smoking and ischemic heart disease, for example. Doesn't mean everyone who smokes definitely have ischemic heart disease, no. But there is some association. This is a risk factor, yeah. These complications are rephrased in writing, so you might think this lecture is too big because of this, but it's not. Actually, this is rephrasing the what I have said. Dyslipidemia, coronary heart disease, obstructive sleep apnea, osteoarthritis or degenerative joint disease, gout, gallstones, cancer, menstrual irregularity, polycystic ovary, venous stasis, nothing. This is summary. أنا شرحتهم كلهم. Your colleague is asking, what did I was talking about before? I was talking about all of these, but in my way. Yeah, always I don't like putting what I'm writing here and reading it to you. This is not a lecture.
احنا مطالبين يعني بتاع الباوربوينت ده مصدر للامتحان.
This is the risk of obesity. This is the risk associated with obesity. Okay? This is not a postgraduate. No. Actually, it's a list. The first one is a list of the conditions what could be associated with obesity. And there is this description of the most important of them. These are the most important. Cardiovascular complications, including ischemic heart disease and diabetes, hypertension, dyslipidemia, type 2 diabetes, metabolic syndrome, gallbladder disease, degenerative joint disease and the gout, cancer, associated cancer, obstructive sleep apnea with hypoventilation. These are the summary of these findings. This is cancer, association with cancer. The most important is the endometrial, this gallbladder, kidney. Are all obese the same? No. Why? Yes, because there is what's called upper body obesity and lower body obesity. The upper body obesity, which is apple-shaped, we usually used to describe it as android obesity. The lower body obesity is pear-shaped, which is gynecoid obesity. This is more risk, more metabolic risk. Diabetes, hypertension, dyslipidemia. What about assessment of obesity or management of obesity? Are there guidelines for diagnosis of obesity? What do you mean by management? What's meant by management? Yes, diagnosis and treatment. This is management. How to assess obesity? He said the skin fold thickness. Do you agree?
BMI.
BMI. What else? Huh?
الويست والابدومين.
Waist, hip, waist. Okay. Actually, these what have you said is part of the answer.
سيرم كوليسترول ولا؟
The answer, yes. The answer first, assessment of obesity itself, the BMI, body mass index, and this is the normal BMI. You have to remember something. The normal is between 18.5 to less than 25. This is the normal. The obese is 30. So between is overweight. Extreme or severe or morbid obesity is 40. So you can classify class 1, class 2, class 3. So you don't have to memorize all this. Just remember the normal and the obese and the morbid obese. But the surgeon like to consider more than 50 BMI as super obese. And 60 is super obese. Yes. Yes. It's written in their books actually. But the guidelines talk about these. Okay? These two persons have the same BMI. 51 kilograms. So, if you didn't examine the patient, just did the weight and the height for him and they calculated the BMI, you might consider this one as obese? No, he's muscular. He is not obese. So, you have to examine the patient and see if this is fat or what. Second thing which is important, the body mass index. Body mass index measures the fat. Is it a direct measure of obesity? No. It's a surrogate measure of adiposity. Indirect measure of adiposity. So, next thing is the waist circumference. Because we said previously that not all obese people are the same. There is android obesity or upper body obesity, and there is lower body obesity or apples and pears. So, which is more important to us? Is the apple. Why? Because they are liable to cause metabolic effects like cardiovascular, diabetes, metabolic syndrome, and so on. So, it's important to measure the waist circumference. Why this point is set? The guidelines say that it's important to measure if the BMI between 30 and 35. Why? Because of what? Why? Because if the patient is more 35 BMI, 35 kilogram per meter square, usually his waist circumference is always over. So it's important to classify the patient, especially less than 35 BMI. If the moderate risk in male 94 and female 80, and high risk 102 in male and 88 centimeters in female. This is to show that the waist circumference, why the waist circumference is important, because it gives us an idea about the intra-abdominal fat. This is the intra-abdominal adipose tissue measured by MRI or CT, and it's correlating with the waist circumference. So when we measure the waist circumference, we are taking into consideration the visceral fat, intra-abdominal fat, which is the most important. How to measure the waist circumference? How to measure it? You know? Actually, there are two methods. One method which was described by the Americans and the ATP3 criteria of metabolic syndrome, which is the measuring tape at the highest point of iliac crest like this and horizontally. So we are including what? The intra-abdominal fat in our measurements. Another method, which is midway between the last rib and the iliac crest, and they take a line like this. We don't, the umbilicus is not important for us at all. It's just the horizontal line parallel to the ground. Actually, this is not the waist. This one is not the waist. Actually, this is the waist. Okay? The second time, what about assessment? Actually, BMI with circumference, scaphoid thickness is taken into consideration. Assessing the motivation for a change, assessing the possibility of binge eating disorder. Some people have something called anorexia nervosa or bulimia. The bulimic episodes are associated with binge eating. Yeah. The patient open the fridge and eats what's in it. These are attacks of binge eating. Then try to throw up when she feels guilty, and they have something like suicidal tendency. So this is important to assist this patient because they need psychiatric help. They could be suicidal. ايه؟ anorexia nervosa is يعني مش عارفه اجيبها لك بالعربي، انا بحاول. I'm trying. Actually they lack نقص الشهيه العصبي او نقص الشهيه العصبي.
الترجمه العاطفيه يعني العين بيبقى ازاي؟
ما انا قلت لك دلوقتي. anorexia nervosa is she looks at herself. She has something called disturbed body image. She looks at herself at the mirror. She says that she's obese while she's thin. So she keeps not eating. She gets severely anorexic. There is another side of this story called bulimia, which is having this binge eating. She's having the same disturbed body image, but she has binge eating attacks, and she tries to vomit to get rid of what she has eaten. Actually, these eating disorders, it's important to look for in obese because it might affect their way of management. We have to assess comorbidity, coronary heart disease, atherosclerotic disease, type 2 diabetes, sleep apnea, identify obesity-related risk factors like osteoarthritis and gallstones. Why should we treat obesity? What are the benefits of obesity? We are asking the same question again. The first answer was, why should we treat obesity? There are hazards associated with obesity. So the second answer is the benefits of weight loss. Here's the benefits of weight loss. Actually, these from the guidelines. Actually, they found that there is a strong evidence of this. There are trials which have proven that they improve lipid profile. If they lose weight, the lipid profile improves. They reduce osteoarthritis-related disability. The patient actually, if someone loses 1 kilogram, actually, as if he gets off about 4 to 5 kilogram pressure over the knees and the back. Yeah. ببساطة شديدة لما الواحد بيخس كيلو واحد كأنه شال تقل 4 ل 5 كيلو معنا على المفاصل بتاعته. The patient after losing even 1 kilogram feel better, can walk and can get her breathe without dizziness, can go up. It's even a modest weight loss associated with health benefits. Lowered all-cause mortality, cancer mortality, reduce the blood pressure, improve the glycemic control, of course, mild diabetes. A patient with mild diabetes, if she loses weight, the diabetes can improve. Reduction of risk of type 2 diabetes also, and potential for improve the lung function and in patients with asthma. This is a study to show that HbA1c and blood pressure and cholesterol improving and the HDL cholesterol is increasing. Why? Why you are so happy about this? Why should we be happy that HDL cholesterol is increasing? Because this is the good cholesterol. What's the LDL, the small cholesterol, low density cholesterol, takes the cholesterol to the circulation, so it can be deposited in the wall. The good cholesterol HDL have high density It takes the cholesterol out of the periphery to the liver to get rid of it. Okay? Is there another side of obesity? What's obesity paradox? Actually, I'm so afraid of telling you this, but I decided to tell you because why? It's not necessarily to be a part of any exam, but you might hear about it from anyone. It's starting years ago. Actually, since about 4 years, I presented it in a lecture in one of our conferences, and it was very surprising to hear from to our colleagues. Actually, it's called obesity paradox. We all say about the obesity have hazards, and there is health benefits of obesity, of obesity treatment. Loss of weight can improve many things, but they found out that if two patients, one of them is obese and the other is underweight or lean, and they're having the same cardiovascular disease or heart failure or whatever, the prognosis of the obese one, especially if she's mild obese, is better than the underweight or lean. So exactly. Yet, if the obese one loses weight, his prognosis is much better also. So this obesity paradox does not preclude the guidelines or saying that we have to treat obesity. Okay? We must not keep it like this. So I'm presenting this information to you because you might hear about it. You might find it anyway. This is postgraduate. This is truly postgraduate.
فين بقى الحنة اللي في الموضوع بقى؟
This is the obesity paradox. Yes, there is something called the French paradox also. There are many paradoxes in medicine. If we have time, I would tell you about, but we don't have time actually.
مش لاقي explanation دكتور ولا ايه؟ مش لاقي explanation.
Yes, there are many explanations. I spent a whole lecture talking about it. I cannot talk about it now. No, it's not alcohol. The alcohol, this is something else. Actually, they say he is talking about alcohol because I will tell you. The French paradox say that they are taking a lot of cheese, a lot of fat, but they are better. They are not having cardiovascular risk like the Americans, for example. They thought this is a French paradox. They thought that it's related to the intake of wine. They thought so. But actually, it's not alcohol. They found out there's some substance in the wine or the grapes called the resveratrol could have health benefits. These are all studies. Yeah. We actually, that's what I'm going to tell you in my next lecture about evidence-based medicine, which is not next week, but it will be planned soon. That we might find out years after years that we have known is changing. Actually, the dean of Harvard Medical School, when he was talking to the student for the first time, he told them, actually, the 50%, remember, 50% of what we are telling you now will turn out to be untrue, to be false. 50% of the information we are telling you will turn out after, for a while, maybe 50 years from now, they are not true. Unfortunately, we don't know which half. Yeah, I'm telling you something. Years ago, 10 years ago, we used to say diagnosis of diabetes. How to diagnose diabetes? First, fasting blood glucose. Fasting, how much fasting blood glucose to consider to be diabetic? Now it's 126. Okay? Years ago, 10 years ago from now, it was 140. Even some of your colleagues at the exam reading from old books, they say it's 140. Something changed, yes, our knowledge changed. Our knowledge, because of the clinical trials, changed. Also, when I was a medical student, we used to hear that the blood pressure, the highest blood pressure, the upper normal blood pressure, 145 over 104 over 95. This is the WHO guidelines when I was a medical student. But it's changed. The upper normal is 140 over 90. What it changed? It's not a human being changing. No. Our knowledge changing. So the science is changing. Okay? So it's not just facts we are giving it to you, it's a way to learn. That's why I'm presenting Give This Medicine to you. It's a way to learn how to practice medicine. How to practice in your way. What do we mean about obesity management? What are the guidelines for obesity? Okay, there are certain guidelines. We stick to it. First, obesity management means assessment plus weight loss plus weight maintenance plus measures to control risk factors. What are the reasons for exclusion from weight loss therapy? Why? Is there any patient I shouldn't, I tell her, no, I cannot do dieting for you? Yes, of course. There must be. عيانين جاي لك عايز يخس بس انت شايف ان عنده حاجه تمنعك انه تخليه يعمل دايتنج. You cannot diet for people with severe psychiatric illness, pregnant and lactating women, advanced liver cell failure. Diabetes needs dieting. Okay, serious medical conditions, psychiatric illness, pregnant and lactating, active substance abuse or mental disorders. Okay? This is the obesity treatment pyramid. This is the base of the pyramid. Lifestyle modification. Then pharmacotherapy, then surgery. This is how to select. Actually, all overweight, more than 25 BMI, should start by lifestyle modification. Then, the obese start with pharmacotherapy later on. But if there is comorbidities, they start at 27 BMI. Surgery, the morbidly obese, or if there is comorbidity, you can start at 35. Okay? These are the guidelines. Remember these figures? Good, because it might be an MCQ and anything. Remember that because it's very important in management. We cannot send a patient with BMI 31 to do a surgery. You know this? What's meant by lifestyle modification? Diet, physical activity, behavioral modification. Okay? These are the guidelines. What's written there is the statement of recommendation. What about dietary modification? Do you remember 3,500 I said before?
Yes.
1 pound of fat equals 3,500. Okay, so if we are going to calculate what is needed daily caloric requirement for you, and then give you a diet 500 calories less. So what's expected from you to lose by the end of the week?
1 pound.
1 pound. Good. Because it's 3,500 calories equals 1 pound. Okay? 3,500 calories over divided by 7 يعني قسميهم على 7 يبقى في اليوم كام؟ 500. يعني في الأسبوع 3,500. 3,500 يساوي كام؟ 1 pound. Okay, so if we expect to lose half to 1 kilogram or 1 pound to 2 pounds. What about the pound? The pound equals what? Half kilogram, about 400 gram. The pound is 400 gram. يعني كيلو رطلين وربع بالظبط كده. Okay? So it's expected that if we do a diet.
ماشي مفيش حاجه مكتوبه من الاول.
ايه؟
مفيش من اول السلايد ده.
هقولها لك تاني. Actually, it's known that 1 pound of fat equals to gain or loss of 3,500 calories. 1 باوند يعني الرطل او اقل من نص كيلو يساوي 3,500 كالوري. خلاص؟ لو احنا قللنا من الكالوريك ريكويرمنت بتاعتك في اليوم 500 كالوري يبقى انت في الاسبوع كام؟ 3,500 يبقى هتنقص كام؟ 1 باوند. اوكي؟ So it's if we are going to give a diet with 500 to 1,000 calories deficit daily, we expect the person to lose half to 1 kilogram or 1 to 2 pounds. Actually, there are some debates about this rule because there is they say that it might be some physiological compensation later on, hypometabolism or so. It's not so rigid. Some people lose less than this. Okay? So it's expected to lose 10% of the weight in 6 months. This is what we know we want. This is the Mayo pyramid. This is the energy density. What's meant by energy density? Actually, it's the food, the content of the food. If it contains more fat and less water, this is called an energy dense. The most dense is butter. Okay, this is butter. The highest energy density food. The lowest energy density is lettuce. خس. Lettuce is because it's full of water and a little fat. Okay. So these are the two trays. الصينية دي والصينية دي الاثنين قد بعض في الكالوريز. فتشوفوا كمية دي كام جرام ودي كام جرام. This is more energy dense. ده شوية لبخ كده مش. So he eats this. He has the same calories but become full, satisfied. Very low calorie diet. Very low calorie diet means calories less than 800 calories per day. I remember when I was in Saudi Arabia, I had a patient. She was 22 years old. She was on diet about 400 to 600 calories per day for a while. Someone gave her this diet, and they came to me with very flabby skin, lost subcutaneous fat, and her skin looks like a 70 years old woman. Actually, the rapid weight loss is not so good because it can lead to risk of gallstones, dehydration, and so this very low calorie diet is have to be, if anyone decides to do it, it has to be for short time under medical supervision. Actually, by the end, this is a very low calorie diet, and this is low calorie diet. So he is losing weight so much like this, and this one is gradually. So at the end, okay, the same. But about this is something fantastic for you. It's not meant for study. Fat diets. What's meant by fat diets? Actually, I will not put it on the internet. When I presented the lecture to Dr. Hussein to put it on the website, I will remove this. I will improve it. Okay? Word? Okay, I will try. He likes to put it in a word format.
عشان يطبعها.
Okay, I will do it for you. Inshallah. But if you like to take it in PowerPoint, it's okay. Actually, the fat diet is something I wanted to tell you about because it's just for your information. The fad diets are the fashion diets. Fashion diets. They are not scientific. So it's not meant for a scientific lecture actually. It's just for you to know something about. It refers to diets and eating patterns that promote short-term weight loss. They lack scientific proving. Cabbage soup, grapefruit, South Beach, low fat, Atkins, and so on. Many on the internet. Protein bar, sugar pasta, zone, Ornish, eat right for your type, blood group dieting, blood group type of diet. So, what? Blood group type, this one is, they think that certain type, for every blood group, a certain food which is suitable for. They thought so. But there is no scientific evidence for that. He thought, Peter Dadamo said that the ancient people started by blood group O. They used it to hunt, so they like to eat meat. Then they settled down and they start farming, and so they develop another blood group and so on. This is something is not scientific actually. So it's not for, this is an eat well plate. Eat well plate, this is some promotion for eating or dieting good. What about exercise, fat or fit? Fit or fat? Fit. Fitness. Yeah. You could be fat and fat at the same time. Why? Because there is benefits of exercise even if you don't lose weight. So, what the aim of exercise is? Physical activity, a part of the multi-component weight management program. We need about 5 sessions per week, 45 to 60 minutes to lose weight. But if you are a healthy person, is not overweight or obese, you need 30 minutes exercise per day for about 5 days per week. This is to become healthy. It's associated with long-term weight maintenance and has beneficial effects. That's why we call it fat, not bad fat. Decrease loss of fat-free mass. This is very important, actually, this one. Because when we diet, we lose both fat and muscle. If we exercise, we preserve the muscles or the lean mass. Okay? So we don't have these flabby muscles. The activity should be slowly and wide varieties and so on. Okay. Exercise alone is enough? No. I said before that if he goes to the gym and they start exercise and eating, he might gain weight, not lose weight. What about behavioral modification? This is the most important actually. Very important. Yeah? Yeah. That you verify, you review your habits and start changing it. Sometimes a patient comes to me and I don't see her after 1 month. Just modify her habits and start to get rid of the bad habits, and she started to lose weight. This is actually the bad habits. Actually, he skipped breakfast. He's in a hurry to go to the work. He doesn't have his breakfast. Chips for lunch. Stays and develop headache. Cookies. Then go to the restaurant. Eat dinner in the car. Try to relax in front of TV. Go to the kitchen, have an ice cream. Bring a cartoon in front of TV. Have another ice cream. And these are the bad habits actually. Behavioral modification includes examine the patient's current eating exercise habits and see what are the factors start changing them. This is self-monitoring diary. مفكرة عامل فيها he ate coffee at bedroom at this time his mood was neutral. He gave cream cheese in the car. He was rushed. He was stressed this time. He had cookies and so on. بسكويت Oreo cookies. Behavioral modification, summary, self-monitoring, low-calorie diet, eat breakfast daily, but its calorie content should be taken into consideration, regular physical activity. The reasons for weight loss is not. What about pharmacotherapy? What about pharmacotherapy? Actually, there were 2 drugs approved for management of obesity. Centrally acting, which is called sibutramine. It's abandoned, stopped in the market. After 9 years in the market, it was stopped. They thought it's cardiovascular risk. I will tell you. I will tell you now. The other, which is very important, is orlistat, which is lipase inhibitor. It decreases digestion and absorption of fat, so it can help in weight loss. Its side effects is diarrhea, flatulence, and oily diarrhea. One of your colleagues is talking about metformin. Actually, metformin is not meant as a treatment for obesity, but it can be used in metabolic syndrome, upper body obesity.
هو اصلا مش بيديكريز، هو maintain البودي ويت مش بيديكريز.
Yes, the metformin can be used as a management of the metabolic syndrome, which is obesity part of it. This is the orlistat. What about bariatric surgery or liposuction? What about liposuction? What is meant by, do you think that liposuction is an obesity surgery? Liposuction is an obesity surgery? Can you answer me? Liposuction is not an obesity surgery. It is a cosmetic surgery. Why?
عشان كل الفنانين هم اللي
No.
بيعملوها. لا اصل هو بياخد من مكان لحد يعني هو مثلا.
Because it doesn't lead to improved metabolic changes. It just remove some fat, superficial, and some skin, making something called body contouring. The bariatric surgery is actual surgery for obesity. It decreases the stomach mass, or lead to malabsorption, which decreases the fat entering the body. That's why it's an obesity surgery. It improves the metabolism. It improves the blood pressure. The more the blood sugar. It's the most, if I ask you from MCQ, the most powerful or the most effective weight loss is bariatric surgery. Yes. Most effective. Yes. Bariatric surgery is indicated when the BMI is 40 or 35 plus comorbidities. Actually, the center is doing it, must be an expert center. It's not anyone who will do it. And taking into consideration the risks. So, and liposuction is a cosmetic procedure, as I said. These are the types of bariatric surgery. There is something called restrictive. What's meant by restrictive? Decreasing the size of the stomach. Either by bending like this, gastric bending, or horizontal or vertical band, or this way, sleeve. What is meant by sleeve? They are cutting 4/5 of the stomach. Actually, 4/5 by something called strappers, like this. دباسة كده بيقطع ويخيط. The kept portion is 1/5 of the stomach. 1/5 of the stomach, this one is kept. So it's called sleeve, like the يبقى شكلها زي الكم sleeve. Okay? Actually, they are moving the gastric antrum also, which is a source of ghrelin, which is appetite stimulant. The patient start eating fluid and semi-solids and start dieting, so she can lose weight. It started first as a part of the preliminary operation before this one, which is called the Roux-en-Y gastric bypass, and now it's gaining popularity alone. Sleeve, they are doing it in our university hospital. Actually, the major side effect is if there is leak here, they putting strips like this, gastric leaking here, but this is surgical technique. And something else, if the patient starts eating again, they can regain weight. Actually, the other Roux-en-Y gastric bypass, this one, they cut it here, they cut the part of the stomach and re-anastomosis and close here and re-anastomosis with lower than the duodenum. So it's both restrictive and malabsorption. It decreased the amount of food and decreased the absorption of food. It's very effective actually. Of course, they have side effects. Very major side effects. It's a major operation, needs experienced center, and it has many side effects. But there is benefits actually, loss of weight, improvement of diabetes, hypertension, and everything, enhanced quality of life, but there are risks of gallstones, nutritional deficiencies, complications, and so on. Other interventions, this is something started in the past and stopped and gaining popularity, which is the intragastric balloon. They put, just by endoscopy, put a balloon. It's meant for short term only, sometimes before the other surgery, and sometimes alone. Actually, the patient feels full, but he might have some colics at the beginning. Then the balloon must be removed within 6 months. It helps him to feel full, so he decreased eating. Balloon is he's asking balloon ازاي؟ balloon why? هيعمل منظار وبعدين يدخل بالونه ينفخها. هي كده بالونه كده بتتباع كده مع اسمها بالون. ما هو بيفضل تعبان في الاول على ما يتعود، معدته بيحس انها صغيره. he feels like his stomach is full all the time. انت عارف لما تحط حاجه مثلا في بقك في بطنك كانك حاطط برتقانيه في بطنك طول الوقت، انت حاسس انك فل، you feel full.
يعني هي البالونه دي مش هتخليه ما يعرفش ياكل خالص؟
لا بياكل بس اماونت صغيره. he feels full so doesn't eat too much. But it sometimes becomes leaked or sometimes everything has its side effects. Actually, the complementary medicine is not, remember, even if it is effective actually, and there are trials, but it's not in the guidelines yet. So it's not scientifically to put it in the guidelines. But actually, there are many scientific trials on it. And there is complementary medicine therapy, hypnotherapy, ephedra, and ephedrine containing, but these have side effects actually. They are effective but have side effects. Hypnotherapy is also effective. Acupuncture in obesity, they found it somewhat effective. Systematic review which has benefits, shows that it has benefit. 2012, February, this is published that obesity, complementary acupuncture is effective in treatment of obesity, but this should not put in the guidelines. This is a patient with acupuncture. This is acupuncture. The future perspectives is just, I will tell you, but it's not for you also. There are many studies of the circadian rhythm changes, how to change the circadian, because they found out that the people eating at night are more obese. So how to interventions to regain the circadian dysynchrony. Also, there is something called brown adipose tissue, which is thermogenic. So, if there is a measure to transform the white adipose tissue into brown adipose tissue, studies of the genomics and genetics, there is something called nutrigenetics and nutrigenomics. These all are the future of obesity research. So, it's not so important for you also, but just I don't know. Actually, I think you might find that you need a lecture for fifth-year student to be just about what is in exam. No, I disagree with you completely.
احنا موافقين ان المحاضره تبقى كده يا دكتور، بس يجيبوا لنا ورقه نذاكر منه سؤال.
Actually, I think the lecture give you something. You can read more even, but I don't have. If I tell you this is not important for exam, so it's okay. Yeah, I tell you this is not important for the exam, so but what is important is the hazard and the assessment of obesity are very important also. These two things, management of obesity is important also. Okay? Thank you. This is me while I'm having my acupuncture course with the Shandong Academy. And this is Einstein telling us that definition of insanity, doing the same thing over and over and expecting different results.